Good afternoon, everybody. Can you hear me? I think we'll make a start. Welcome to the Glaucoma Uveitis Rapid Fire Session. I'm Jennifer Van Gaskin from Melbourne. I'm very pleased to be co-chairing with Dr. Graham Hay-Smith from Brisbane. This afternoon we've got a fantastic lineup of presentations. So without further ado, I'll invite Dr. John Landers from Adelaide to come up to give the first talk.
Alrighty. Thanks a lot, Jennifer. Now, today I'd like to present the 3-year results from the Avastin in trabeculectomy study. So this was a study to assess the effects of adjunctive intravitreal bevacizumab in the form of Avastin on bleb function, in addition to conventional augmentation with mitomycin at the time of trabeculectomy. The study was a single-centred, double-blinded, randomised controlled study in which patients were randomised either to receive intravitreal Avastin or intravitreal balanced salt solution. We used a standardised protocol of a fornix-based trabeculectomy with adjustable sutures, 0.4% mitomycin for either 2 minutes for low-risk patients or 3 minutes for high-risk ones, and a tapering dose of topical dexamethasone over about a 3-month period. The primary outcome was based on the achievement of a target intraocular pressure that was predefined using the CIGITS criteria. That was a metric of preoperative visual field loss and intraocular pressure. Trabeculectomies achieved complete success if they were below the target pressure on no medication. They were considered to have achieved qualified success when considering all of those who were below their target with or without topical medication. And they're considered to have failed if they were above their target pressure on topical medication and or requiring glaucoma surgery, further glaucoma surgery. We also assessed the effect of Avastin on visual field progression as a secondary outcome in a post-hoc manner. This utilised the visual field index plot from the Humphrey Field Analyzer and compared the change in slope of visual field progression before and after surgery. Patients were included in this aspect of the study if they had at least 4 visual fields in the 2 to 3 years prior to surgery and following surgery. So we recruited 131 patients over a 2-year period. These were evenly matched across the intervention groups for age, sex and glaucoma type. At the 3-year mark, there were 13 deaths and 9 losses to follow up, leaving 109 patients at the 3-year mark, although 114 of these had contributed about 2.5 years of data. So both groups demonstrated a significant and sustained drop in intraocular pressure throughout the study period, although those who received Avastin had significantly lower intraocular pressure at the 1 month mark, with both groups becoming similar after that. However, the control group required more topical medication throughout the study period to achieve target pressure, with this becoming significant by the 6-month mark. Those who received intravitreal Avastin were significantly more likely to achieve target pressure off medication throughout the study period. In addition, they were significantly less likely to require further surgery compared with controls. 121 of the 131 patients were followed for at least 2 years, of whom 102 had at least 4 visual fields pre and post-operatively. For the whole group, the slope of the VFI plot progression reduced significantly by 2/3 following trabeculectomy. And when we considered the effect of intravitreal Avastin, we could see that the groups were similar preoperatively, but that postoperatively, those who received intravitreal Avastin had a VFI progression slope that was about 60% more shallow than controls. So our work is novel in that it looks at intraoperative Avastin in trabeculectomy when it's injected intravitreally. Previous work has involved subconjunctival or intracameral location, which resulted in no added benefit from Avastin. Avastin modulates the proliferative phase of wound healing, which extends over a 3 to 4 week period. And when introduced subconjunctivally, Avastin only sticks around for about a week or two. However, intravitreally, it can last up to 3 months, which then covers this proliferative phase. When trabeculectomies are followed over time, the period during which the most rapid failure occurs is during this first 2 to 3 months, meaning that intravitreal Avastin is well placed to interrupt this process. So in conclusion, intravitreal intraoperative Avastin results in a 70 to 80% reduction in the need for additional medication and further surgery to achieve target pressure at 3 years post-trabeculectomy, and a 60% reduction in post-operative visual field progression. So further work should be done to replicate these findings and investigate which subgroups might benefit from this intervention most. Thank you.
Do we have any questions?
John, fantastic work. Now, obviously, you couldn't predict the future when you did this, but with the issues with Avastin now,
Yes.
what's your advice to us going forward?
Well, I've changed over to using MVASI with no problems at all. The problem with using the other drugs such as Lucentis and Eylea is that they're not indicated. So that would be need to be something that would need to be worked on in order to get approval to use these drugs intraoperatively. But I imagine that would work just as well.
You're able to access it.
I'm able to access MVASI, yes. We have access in private and public, so it's no problem at all.
So it looked like there wasn't a difference in the intraocular pressure in the longer term.
Yes.
There was medication.
Yes.
So did you have a protocol for adding back the medications, or was that just investigator discretion?
It was investigator discretion. They didn't, we didn't know who had received Avastin and who didn't, and it was really based on when a person's intraocular pressure wasn't sufficiently lowered, and that really was done without knowledge of the drug that they received. The 1 year data that I presented at the glaucoma meeting back about in beginning of 2020, I presented those results then, and no, there was no increased hypotony or wound leaks. You do, however, have to modify your technique when you start using Avastin, because that is a possibility that can happen. My patients, they don't have a problem with high pressure, they have a problem with low pressure, and so I tend to tie up my my adjustable sutures much tighter than I would otherwise do it, and then loosen them off over the first couple of days, and then things go well after that. But if you try and use, if you have them still flowing on the table, and then sort of with pressures that are a bit low on day one, they tend to go low. Simon.
Yeah, just following on from Mitchell's point, this issue of protocol for reintroducing drops, it's come up more than once in this conference, and it's obviously going to be an ongoing issue. Just a comment, just like we've standardised how to report absolute qualified success, we should think about how to standardise this issue so that when we're talking about different papers, there's an accepted way of reintroducing drops.
Yeah, absolutely. I mean, as I said, each patient had a personalised target pressure that they were allocated to, and so with the analysis, which was done, as I said, we were blinded as to who received the drug. But when we did the analysis, I then compared what people's pressure was to what their target pressure was to work out whether they were actually above or below that. But yes, I guess that can be something that's a bit more protocolized for future investigations. Yeah. Yes.
Probably out of time.
Out of time?
For questions, so maybe let you off the hook.
Sure thing.
And if I can now ask Dr. Ashish Agar to come up to the platform. Just before he starts talking, at the back, were you able to hear that question and answer discussion at all? Because we do have some microphones here, so I might just, at the end of this one, put a microphone up at the back so that if you did want to talk there, everybody in the room can hear what's being asked and what's being said.
Thanks, Graham. Yeah, look, it's interesting looking at the room. It's a bit like a school bus, like everyone's at the back and like everyone's scared of coming at the front. So if you can't hear, you're more than welcome to come down this end. Look, thanks for this opportunity. I wanted to talk to you about the Spectrum data. When the Hydrus had rolled out in 2016, the only way we could get access to the device was by agreeing to sign on to the Spectrum registry. So basically, what the registry involved, it was no restrictions because it was real world, and there were no exclusions. So our learning curve was part of a registry. Every failed insertion, every malposition, everything was part of it. I think that's what gave us confidence as we were going forward, that we had a very, very rigid, almost mandatory registry. It was a diverse population. The follow-up has been ongoing. I'm going to talk about the 5-year data, and I'm going to be concentrating on standalone. When Spectrum started, it was particularly started here in Australia and New Zealand. We had about a dozen sites, and then it's a correction there, sorry. It should have written 14 countries. So it then expanded to go beyond that. But most of the stuff we're going to talk about was Australia and New Zealand. About 3,000 by 5 years. I remember very clearly the learning curve, very clearly the tentative first steps in starting it. But the part I'm going to talk about was standalone, which is about a quarter of the insertions. This is relevant because when we had to go to government and advocate for MIGs and then standalone MIGs, we needed to try and differentiate the patient populations. If you look there, most of these are POAG, and there was a small group who'd had primary surgery. The group I'm going to talk about are those ones that were only POAG. The only previous surgery they were allowed to have was SLT, so nothing incisional. There's a small number of missing eyes. We're looking at about 400 in this data set. So if we look here, we have an initial drop, and most people that do MIGs or similar devices will know that there's a nice initial drop, and then it does tend to creep back up. But over time, if you'll see that there is definitely a long-term reduction in pressure, not fantastic, but certainly useful, from 20 down to about 15 to 16. And the medication drop, once again, an initial early drop by one day, but then over a month, and we're going out to 5 years there, it tends to tail off and flatten out a little bit. If we look at the dot plot there, we can see what we all know as glaucoma surgeons, which is, you know, the bigger they are, the harder they fall. So the higher intraocular pressure corresponds to a greater reduction in intraocular pressure following surgery. And that, of course, is pretty universal across most of the procedures that we do. If we look at adverse events, certainly one of the issues that we're noticing has been about peripheral anterior synechia. However, most of these, at least 3/4 of these, are not related to what we'd call obstruction or failure. You see PAS there, but it seems to be sitting there quietly. And I think that's because the mechanism of the device is threefold, that you not only have access to Schlemm's canal, but you also triple the size of it, and you have about 3 clock hours being included. They were relatively small procedures. There were 2 malpositions, as I said, and I've had to explant 2 over the past 6 years related to iritis. But particularly early on, I was doing a more advanced group, particularly starting off. You really want to be very careful. And I think what's given me confidence is that we're all looking for the perfect operation, which has got reliability, etc. But for me, the location aspect was key, that once you do the device insertion properly, you know that it's going to be in the right spot. So I think that really is what allows us to have some confidence. But the other thing, of course, is that everything that was done in those 5 years is in here. So there's nothing that's missing from this data set. Thank you.
So plenty of time for questions there. Have we got any questions for Ashish? So I'll have a question for you then.
Yeah, sure.
So I was also on the original Spectrum registry, as you know, and I continue to use this device, but I know that the device is much less used across Australia compared to some other MIGS devices. Why do you think that is?
Look, if you look at the rollout, the iStent was very much targeted at general and cataract, and that's a bigger cohort. And clearly you're going to get the numbers up there. And I think they actually acknowledged that. And that's why the initial MSAC applications that we were involved with were for combined surgery. And so as a glaucoma specialist, for me, this had to be a glaucoma procedure, and it took longer to get that. So I think it's the history of it. It's picking up over time, but I think there are issues to do with how it was presented and how it was rolled out. And of course, I will say the learning curve is a bit longer for this than it is for the iStent. That definitely is something that makes an easier proposition. But I think that once you get over the learning curve, I think it actually ends up being a much more reliable insertion technique in terms of location. Mitch?
Thanks, Ash. It's great to have 5-year data. That's fantastic. Do you, in the registry, do you have structural or functional parameters to look to see whether you've modulated the course of the disease over 5 years?
Yeah. There is some. I tried to stick to the 5-slide limit, so I haven't got all of that here. But yes, we did look at mean deviation. We looked at BCVA, and I think that's the stuff we need to really drill out.
Could you pick up any difference, or numbers are not big enough?
Yeah, I can't remember off the top of my head. Stunned silence.
I've got a question. In the
Yeah,
two
you can-
cases that you had to explant
Yes.
because of uveitis, do you think that was due to positioning, and did the uveitis resolve after you explanted?
I think one of them was positioning. The other one I don't think was, and this is early in the piece, and it was like, okay, I'm not sure if this is part of the issue. I'll take it out. What was reassuring is that the explant wasn't that difficult.
Yeah.
It came out relatively easily, but one of them did definitely improve following it. The other one, I don't think it was actually the causative factor.
Right, so no further questions. Thank you very much.
Thanks.
Next up, I'd like to introduce Dr. Colin Clement from Sydney to give his talk.
Thanks very much, Chairs. It's my pleasure to present to you this afternoon this study on behalf of my co-authors, looking at the outcomes of combined eye stent inject with cataract surgery from the Fight Glaucoma Blindness Registry. So currently eye stent inject is the most commonly used transtrabecular mixed device in Australia, and it's most commonly combined with cataract surgery. So we sought to use the statistical power of the Fight Glaucoma Blindness Registry to assess outcomes in Australia. And this really fills a gap in the literature where most of it's focused on either randomized clinical trials, retrospective studies, or, single surgeon studies. So this is giving us information about point of care outcomes. The outcomes of interest were intraocular pressure, medication reduction, and adverse events. And we looked at these at 6, 12, 24, and 36 months following surgery. So this is the baseline for each of those time points. If we just focus on the total cohort, there were 2,051 eyes, roughly 50-50 gender split with a mean age of 73 years. The largest cohort was primary open-angle glaucoma, which was 50%, and then equal numbers of normal tension glaucoma, ocular hypertension, POG and NTG suspects, and secondary open-angle glaucomas. The baseline IOP was 16.4 on 1.5 medications, and the mean deviation of minus 4.7 suggested that the glaucoma was on average mild. So these are the IOP medication outcomes. So at 6 months from 1,321 eyes, there had been a 16.7% reduction in IOP with a 50% reduction in medications from 1.6 to 0.8. That reduction in medication was sustained throughout 36 months of follow-up. However, intraocular pressure reduction diminished over time, and at 36 months was 7.7%. Now, it's common with glaucoma surgery studies to report success, and there is standardized definitions of that, which usually involves a percentage reduction in IOP within a target, with or without medication. Now, we did do those calculations. However, for this particular study, we created a new definition which more accurately reflected the intended purpose of the treatment. So in some cases, it was not the intention to reduce pressure at all, but just to reduce medication burden for the patient. And that's reflected in these results, which I would argue is perhaps more relevant to the patient at the clinic, because when you're consenting them for surgery, they want to know, what is my chance of achieving outcome A, B, or C? They don't want to know what the average pressure reduction is. So the first group, any IOP, so this is any reduction in pressure compared to baseline with the same or fewer medications. Any med reduction with the same or lower intraocular pressure, and group C was both the intraocular pressure reduction and medication reduction. And we calculated this at 12 months, and any IOP reduction, 74%. Any medication reduction was 51%, and if you achieved both outcomes, there was a 46% chance of getting that. Now, the table below looks at the a number of variables that potentially predict these outcomes, and we found that for any IOP reduction, not surprisingly, our higher baseline intraocular pressure increased your chances, as did increased age. For any reduction in medication, it was higher baseline IOP or higher baseline medication, and same for both IOP reduction and medication reduction. In terms of adverse events, over the entire follow-up, 36 months, the most commonly reported adverse event was subsequent procedure at 11%. The majority of these were laser, SLT to further reduce intraocular pressure or reduce medication. There were some filtration surgeries as well. At 36 months, 2.8% had experienced a greater than 10 millimetre increase in pressure. So in conclusion, the Fight Glaucoma Blindness Registry is able to capture large amounts of data prospectively and is a valuable resource for understanding point of care outcomes. In this study, iStent combined with cataract surgery resulted in both reduction in intraocular pressure and medication across a range of glaucoma subtypes, and adverse events overall were few, and most consisted of requirement for further laser procedure to reduce intraocular pressure. Thank you.
Open up for any questions.
I'll shout. Your IOP reduction, did you look at percentages that achieved a 20% IOP reduction, or was it literally 1 millimetre less?
No, we did that analysis also, but I didn't report it here.
Do you have a rough idea of what the 20% IOP reduction rate would be?
It's around 20 to 30%, I think. Yeah.
That's exactly what we've done, actually.
Yeah.
I know this is from the registry, so you know, but what's the general consensus about doing SLT post iStent? Do we still find that it's successful? Any comments on that?
I can only comment on my personal practice, and I don't really do it.
No, yeah, I was surprised that you said that.
Was there a breakdown between the inject and the original? Is there any differentiation?
This doesn't include G1 stents. This is only iStent inject, and also captures some of the iStent inject W, which is just a modification to the flange. Yeah.
Bill?
Of the iStent, that is, whether it was through the ciliary body or meshwork or scleral spur. Did you look at that at all?
So the registry does capture whether the stent was implanted successfully at the time of surgery, and whether there's two stents in place. I think that's all we have on that. Yeah.
I know the study wasn't designed to look at this, but could you speculate about what percent of the reduction in meds or IOP is related to the cataract surgery against the iStent? So, you know, I guess the way to look at it, that would be primary iStent with no cataract, or some sort of trial where you did phaco alone versus phaco iStent.
Well, that study's been done.
Yeah.
You know, FDA clinical trial.
So what
with
I'm
2 years of
asking you
follow-up.
is what percent of the reduction is because of the cataract, and what's the percent from the iStent?
Well, I mean, in the FDA trial, it's actually hard to tease that out because of the way they report the data, because they talk about percentage of eyes for achieving a certain IOP reduction rather than mean IOP. But I think the difference is the cataract-only group, about 50 to 55% achieve the outcome. And when you add in the stent, it increases to about 75%. Yeah.
Thank you. Thank you, Colin. In the interest of time, better move on.
Thanks.
Next, I'd like to ask Dr. Mark Hassel to come up to give his talk on neuroglobulin gene therapy Oh, sorry, actually. Sorry, I got that wrong. It's Linda.
Linda Deng, yes.
Yeah, sorry. Skip one. Linda Deng to talk about online circular contrast perimetry, a comparison to standard automated perimetry.
Thank you very much. So glaucoma is one of the leading causes of blindness worldwide, and frequent surveillance is essential to improving patient outcomes. Currently, conventional perimetry occur in clinics, and access to this is limited in regional and remote areas. Other issues associated with conventional perimetry include the cost associated with purchasing equipment, their maintenance, as well as hiring trained professionals in their delivery. It's also a labour-intensive process that some patients find claustrophobic and stressful. Online perimetry is an alternative to conventional perimetry and offers many benefits, including improved access, clinic flow, as well as a reduction in cost associated with their delivery. It can also offer a more enjoyable experience for the user, as well as the flexibility of taking these tests outside of clinic-based environments, including at home. This can help to promote frequent surveillance and may allow for earlier detection of disease and disease progression. Our study aims to validate an original form of online perimetry, the OCCP test, as a diagnostic tool for glaucoma in a large patient cohort. OCCP is designed as a web-based perimetry that can be taken on any computer screen. It uses a spinning star as a fixation point, as well as flickering test targets consisting of concentric, alternating light and dark rings to stimulate areas of the visual field. The light rings are set to a background screen colour, which is light grey, whilst the intensity of dark rings varied to achieve the desired level of contrast. Correct viewing distance is determined at the beginning of the test using blind spot localization. The user will be prompted to readjust their position based on their predicted blind spot relative to the fixation point. Correct head positioning throughout the test is monitored using an inbuilt web-based face detection system. However, for purposes of this study, a trained orthoptist determined and monitored the head height, position, as well as viewing distance throughout the test. Visual field reports generated by OCCP and SAP demonstrate very similar outcomes across all disease states. OCCP was also able to demonstrate a shorter test duration than SAP. And in addition to this, a published study has demonstrated that users preferred OCCP over SAP on a 10-item experience survey. A total of 220 participants were included in this study, 95 of whom had glaucoma, 125 without. Area under the curve was generated for OCCP and compared to other conventional tests used in the diagnosis of glaucoma. Looking at its trend line, which is this one up here, as well as its total area, OCCP mean deviation demonstrates a similar degree of diagnostic accuracy to other parameters tested. Blunt-Altman plots were generated to assess for overall agreement between OCCP and SAP. To allow for equal comparison of sensitivity thresholds across different devices, OCCP and SAP decibels were converted to a common unit of measurement, the log contrast sensitivity, and this was applied to both mean sensitivity per eye and per point. Overall, OCCP demonstrated a bias of 1.02 log units for both parameters. The 95% limits of agreement for point-wise sensitivity was between 0.86 and 1.17, whereas the limits of agreement for mean sensitivity per eye was between 0.37 and 1.66. The point-wise sensitivity threshold estimates were subsequently divided into 8 zones, and regional agreement was further assessed. All zones except for Zone 1 demonstrated good to excellent reliability through their ICCs with a statistically significant p-value. The Pearson's correlation coefficient for all zones also centered around 1, demonstrating a strong positive correlation between OCCP and SAP point-wise estimates. In conclusion, a published study has already demonstrated that users preferred OCCP over SAP. This large patient cohort study has demonstrated that OCCP has similar perimetric and diagnostic metrics to other modalities used for glaucoma diagnosis. Therefore, online perimetry on personal computers is possible with many benefits. Thank you.
So have we got any questions? Right at the back.
Is there any reason why this should be a standalone?
Do you mean?
On a device, install it, and standalone, and store a database there. Why does it need an online service as opposed to a program that's installed?
As opposed to a program that's installed on mobile phones, tablets, or?
PC or an iPad or whatever it is you're going to use?
That's a very good question, and that's something that we haven't really looked into in terms of app development. At the moment, it is designed as a sort of a web-based program with a website address that patients can click into and perform the test on there.
Thanks. It looks kind of similar to Lars Frisen's ring perimeter, which was, I think, described about 20 or 30 years ago. I'm interested in the variability. Have you measured the variability of measurements, within 2 or 3 sessions, the same patient? The value is really going to be judgment of progression. So.
Yeah, absolutely. So I do recognise that for this particular study, it's looking at diagnosing glaucoma at one point in time, differentiating that from normal eyes. We haven't really explored the stability or the variability over time in this particular study. However, after completing this paper, we have actually brought some participants back a few months down the track and asked them to retake the OCCP test. I don't have a slide of the visual field reports in this particular presentation, but I can tell you that the visual field reports for patients with stable disease demonstrated a great deal of consistency over time, and it was also able to detect some visual field changes in patients with progressive disease. We do actually have an e-poster out there which has the printout of visual field reports by the same patient across a couple of months.
Okay, so thank you. No other questions?
Thank you very much.
So now I'm going to ask for Mark to come up to give his talk on neuroglobulin gene therapy for retinal ganglion cell neuroprotection in a rodent model of glaucoma.
Thank you. This work is funded by an AUREA New Investigator grant, so thank you to AUREA for supporting this work. As we all know, intraocular pressure is the only modifiable risk factor for treating patients with glaucoma, but there are many examples that you could all probably draw on from our personal experience of patients that have a good pressure after trabeculectomy, or perhaps an NTG patient who's had some IOP lowering treatment who still continue to progress. And so neuroprotection has an important role to play in a subset of patients for whom IOP lowering therapy is inadequate. And a good example of this idea is the brain-derived neurotrophic growth factor work pioneered by Professor Keith Martin in Cambridge in his time there. We looked at neuroglobin, which was identified in our clinical registry of human patients here in Australia. In the ANZRAG registry, 3 families showed either missense or exon deletions in neuroglobin associated with their phenotype of glaucoma. And so we looked at expressing neuroglobin in rats as a way of looking at this. The top left shows you a schematic which explains the internal DNA design of the virus. I guess the key take-home message here is that it not only expressed neuroglobin, but it also expressed a labelled marker, a green fluorescent protein, which will allow you to see some of the expression as we go along. The delivery mechanism in this rat model was an intravitreal injection. We overcame some of the technical challenges of a very large intraocular lens in the rat, a 3mm eye and a 2.5mm lens. And in the top right, you can see just the en face appearance of the architecture of a rat retina. And then the 3 panels across the bottom show to you the expression of the virus in rat retinas. So on the left, you're seeing a confocal scanning ophthalmoscopy image of a placebo-treated eye. In the centre panel, you're seeing green fluorescent protein in a black and white grayscale image, showing both the axons as these sort of radial fibres, as well as the cell bodies expressing, in this case, green fluorescent protein, which also means neuroglobin. And we were able to optimize the delivery by using pronase enzymes to digest both some of the vitreous and presumably some of the inner limiting membrane as well, to increase that expression to be more global. At a microscopic level, the green fluorescent protein and thus the neuroglobin expresses quite broadly throughout ganglion cells in the retina. And you can see here this co-localization of both green fluorescent protein and neuroglobin alongside beta tubulin as a marker of retinal ganglion cell neurons in the retina, and those two overlays demonstrating the co-localization. We also demonstrated that it's not toxic to the retina, putting these viruses inside. You know, if you do a full-field ERG on a rat, which you can do, that shows that the A and B waves are similar in treated and sham-treated eyes, and that also if you do an OCT of these eyes, that there's no retinal toxicity, there's no loss of architecture, the structure is preserved. So then we went on, after optimizing that delivery and showing no toxicity, to explore the intraocular pressure model, which is a well-documented model using a photocoagulation laser to obliterate episcleral aqueous drainage for 270 degrees of one eye. You leave a small portion of nasal episcleral drainage so that there's not a calamitous IOP rise of 70 or 80. And you can achieve some pretty sustained intraocular pressure rises in the treated eye, that if you top it up after about a week, you can get 2 or 3 weeks of good sustained pressure. And that allows you to then test whether or not these gene therapies are neuroprotective. Our main outcome measure was in those animals that had been pre-treated with a virus, had shown expression, and then went on to have elevated intraocular pressure. We looked at the survival of retinal ganglion cells using a marker of BRIN3A, which is just an expression marker of that cell type in the retina. And what you're seeing here in this green image here is flat mounts of retinas of animals that have been treated with virus. And in the top 2 panels, you can see that in those animals, in those eyes that had no laser therapy, that is to say they had normal intraocular pressure, that there's no toxic effect. The bar graph is slightly dissolved on the right-hand side, and I'll come to that in a moment. But you can see that there's no toxic effect in the 2 untreated or placebo-treated and treated eyes. And in the bottom panel, you can see in those representative images that in animals that have been treated with laser, that they have elevated intraocular pressure. If they've been also injected with neuroglobin gene therapy, that they have a higher number of surviving retinal ganglion cells. So on the left is a placebo-treated eye, and on the bottom right is a representative slide of the higher density of retinal ganglion cells. The graph on the right just replicates those pictorial images, with the full data set from the cohorts of animals that we injected, and show that there was a significantly higher number of animals with significantly higher number of surviving retinal ganglion cells in those animals that have been pre-treated with neuroglobin gene therapy. There are also bars on that bar graph that are not there right now. So in summary, we demonstrated that this vector is effective at delivering neuroglobin to retinal ganglion cells, that it is safe and can be delivered to the correct part of the retina without causing cataract or toxicity, and that when the elevated intraocular pressure model is applied, that there is retinal ganglion cell neuroprotection. Thank you.
Do we have any questions? I have one. What do you think the mechanism of action is with neuroglobin?
Neuroglobin's a 151 amino acid protein. It's pretty small. It's involved in mitochondrial cytochrome function, so in the mitochondrial electron and respiratory train. It also has some role in mopping up reactive oxygen species that could also be harmful in mitochondria. The presumed role is through those 2 mechanisms, potentially through more availability of mitochondrial derived energy for ganglion cells under stress, and potentially also mopping up some of reactive oxygen species.
And looking down the track, if it were to become a clinically available treatment, do you think the treatment delivery is going to be an intravitreal injection through a viral vector?
Yeah, it's a good question. A lot of the inherited retinal diseases, the classic is Lux-Turner, are delivered by a subretinal injection of gene therapy. When you're targeting photoreceptors, that's a good anatomical location for delivery, but going for retinal ganglion cells would be more appropriate, I think, personally, to go for an intravitreal method of delivery. I guess it would be lower cost and more accessible in the clinic if that would be the final way that you were to deliver gene therapy for neuroprotection.
And do you think it will be a sustained treatment, or will it
Yeah.
require repeated injections?
That's a good question. These were short periods of time. These animals were pre-treated. The viral vector, depending on how you design it, this thing had a universal mammalian promoter that just turns on and stays on and produces neuroglobin indefinitely in the cells that are transduced. So, theoretically, you should be able to inject once and have sustained response, but I think you'd probably be guided by some of those IRD clinical trials as to whether you need to top it up based on the promoter.
Great, it's very exciting.
Well, thank you very much. And next, I'd like to ask Dr. Samantha Lee to come and give her presentation.
Thank you for the introduction. I'll first like to acknowledge my co-authors listed here. As we all know, glaucoma is one of the most highly heritable disease with a narrow sense heritability of up to 93% reported. Hundreds of genes associated with glaucoma or its endophenotypes have also been identified. This study aims to explore associations between polygenic scores of primary open-angle glaucoma or its related traits with IOP and optic disc measures. And we also want to compare how these relationships may differ in community-based young and older adults. So about 1,300 young people attended an eye examination when they were around 20 years old, and a subset of them returned for a follow-up 8 years later, while about 5,000 people aged 45 and above attended an eye examination at a single time point. Phenotypic measures included IOP and OCT measures of the RNFL thickness and minimum rim width. Participants were genotyped and their polygenic scores for POAG, IOP, and vertical cup to disc ratios were generated. This plot shows the results of the IOP single trait analysis with the IOP of the young participants on the y-axis and the IOP polygenic score decile on the x-axis, with higher decile representing a higher genetic risk of IOP elevation. And you can see that there is this rough upward trend of increased IOP with higher polygenic score decile. And the R-squared was 2.1%. When these participants returned 8 years later, somehow their IOP decreased, but there was still an upward trend with an R-squared of 1.5%. However, there was no association between polygenic scores and the change in IOP over the 8-year period. In the older cohort, there is a much neater upward trend. That's because of the larger sample size and also the smaller standard errors. However, the R-squared was still only around 2%. Now, this 2% in these two cohorts is honestly a little lower than we expected, because a previous study found that polygenic scores explain up to 17% of the variance in IOP. So these differences between studies could be because of the different methods of tonometry used, and we also were not able to account for corneal biomechanical properties in our study. In a cross-trait analysis, we found limited associations between RNFL thickness and polygenic scores for POAG in the young cohort when they were 20 years old. When these participants returned 8 years later, we noted a 2 to 4 micron thinning of the RNFL, but still limited genetic associations were present, maybe just with the exception of the nasal sector. In the older cohort, the association between RNFL thickness and POAG scores was also not great, maybe with just weak associations found at these two sectors. For the minimum rim width, we were not able to measure it when the young people came when they were 20 years old. That's because the module wasn't available on our OCT back then. But we did do it when they were 28 years old. And we found that higher polygenic scores for POAG was associated with reduced minimum rim width at the superior sectors. Even stronger associations were found in the older adults, where higher polygenic scores for POAG was linked with reduced minimum rim width globally and at all sectors, with a p-value of less than 0.001. We further noted that higher scores for IOP or VCDR was linked with reduced minimum rim width in the older cohort, although these associations were not as strong as what we saw with the POAG polygenic scores. In the young cohort, however, limited relationships were noted for polygenic scores for IOP and VCDR with any optic disc measures. So even though we found some associations between PGS and glaucoma endophenotypes in the young cohort, the link was still stronger in the older adults. So this could be because of a greater manifestation of these genetic effects with age, but it could also simply because we just had a smaller sample size of young people. We'll continue to follow up these two cohorts of young and older adults over time, and that would allow us to map the longitudinal change in IOP and disc measures and see at which point we can see the genetic effects manifest. Thank you.
So are there any questions? I've got one question then for you. Maybe you could expand a little bit on what your actual polygenic scores were.
Yes, I had to cut that part out because of the time limit. It was explained pretty well yesterday in one of the best paper presentations. So it is taking the cumulative effects of all of the hundreds of genes to come up with an overall score, of overall genetic risk score for that particular trait.
And how are you establishing that the genotype?
So a genome-wide association study, it was based on the results from genome-wide association studies. So for the purpose of, just for the purpose of our analysis, we took all the genes that reached genome-wide significance and calculated a score from that.
And any other questions from the floor? Genetics has that effect sometimes on an audience. We've got one question.
The variance or the R-square values, so they're relatively small, which is kind of disappointing. I'm sure you would, I mean, I was disappointed. How do they correspond with other studies that have done this? I mean, perhaps Jamie could comment, but I'm assuming that there might be some quirk in the system as to why those variances were relatively small. But I'm just wondering how they compare with other work that you're doing or others are doing using the polygenic risk scores.
Yep. So I believe there was one study by Anthony Kawaja, and the R-squared there was reported to be 9 to 17%, depending on the cohort. So that was obviously much larger than what we found. They did use a different method of tonometry, and which accounted for corneal resistance factor, I believe, and central corneal thickness. That could be one reason why ours was so small, because we just used a rebound tonometer, which doesn't account for those factors in our study. So for the young cohort, we have central corneal thickness measurements, which we are looking at seeing how much that would affect the outcome if we account for that in the analysis. But for the older cohort, unfortunately, we don't have those corneal measures. So I agree, it is quite disappointing.
Just one comment. I mean, it'd be a little bit like looking at a risk score for macular degeneration, and you've got a 99 percentile risk, and then examining 15-year-olds and finding no macular degeneration, a little bit. Mm-hmm. So 28 is like you don't have any aging effect on your meshwork. And so the genes probably cause aging disease. Yeah, 45, but like how many patients we don't, I mean, I'm just speculating.
Yeah,
I think you're talking about aging pathology, and the genes are found in glaucoma data sets and older people. That's probably why it's different, I think.
Yeah, that's also cohort differences, geographical differences, and ethnic differences could make a difference as well.
Thank you, Samantha.
Thank you.
We better move on. So next up, we've got Dr. Camilla McCree talking about blood pressure measures and incident primary open-angle glaucoma. Yes, it should be on.
Okay, cool. Hi, my name is Carmelo. I'm presenting our study, Blood Pressure Measures and Incident Primary Open-Angle Glaucoma. The authors have no financial disclosures, but the UK Biobank that was used in this study was established by the Wellcome Trust Medical Charity, the Medical Research Council, Department of Health, Scottish Government, and the North West Regional Development Agency. So cross-sectional studies have shown an association between systemic blood pressure and primary open-angle glaucoma. However, the few available longitudinal studies have observed inconsistent associations. Comparing results is complicated by different approaches to representing blood pressure in statistical models, the range of blood pressure parameters included, definitions of high and low blood pressure, and the boundaries used to discretize categories. The objective of this study was to investigate the association of a range of blood pressure parameters with incident primary open-angle glaucoma in the UK Biobank. The UK Biobank study is a prospective cohort study including over 500,000 participants aged 40 to 69 years recruited between 2006 and 2010 across the United Kingdom. We included 484,268 participants of the UK Biobank without glaucoma enrolment. Prevalent and incident glaucoma was identified through interview at baseline, interview at repeat assessment visits, and diagnostic codes from linked hospital and primary care data. The primary outcome assessed was the hazard of developing incident primary open-angle glaucoma during the follow-up in the biobank. We used Cox regression to estimate this hazard. Blood pressure was included in multivariable models as a time-varying predictor to incorporate repeated measures throughout the study period. Blood pressure was represented as restricted cubic splines with 4 knots at the 5th, 35th, 65th, and 95th percentiles. This allowed the inclusion of blood pressure as a nonlinear continuous variable without the need for categorization or assumptions about the shape of the association. These multivariable models were adjusted for age, ethnicity, BMI, education, Townsend Deprivation Index, smoking, alcohol, prevalent diabetes, and prevalent cataract surgery. There were 2,390 events of incident primary open-angle glaucoma over a median follow-up of 12.08 years. Kaplan-Meier plots showed overall that the increasing systolic blood pressure, pulse pressure, and mean arterial pressure were all associated with high rates of incident glaucoma, but diastolic blood pressure was not. Plots of hazard ratios for incident glaucoma showed that systolic blood pressure and pulse pressure showed a significant association, but diastolic and mean arterial pressure did not. A systolic blood pressure greater than 120 compared to 120 millimeters of mercury showed an increased hazard, whereas a systolic pressure of less than 120 was associated with a decreased hazard. A pulse pressure greater than 50 compared to 40 millimeters of mercury showed an increased hazard. In summary, high systolic and pulse pressure significantly increased hazard for developing glaucoma in the UK Biobank cohort. However, the effect sizes were small. Our study was limited by using self-report and diagnostic coding to define the primary outcome. Primary care data was only available for a subset of the participants, and we were not able to account for undiagnosed cases at baseline. We could not adjust for intraocular pressure or central corneal thickness, as this was not available for the whole cohort. The predominantly Caucasian population prevents generalization to other populations. Our findings support existing evidence for a potential role of systemic blood pressure in the development of primary open-angle glaucoma, but the effect size is likely small. We did not observe a U-shaped association, as has been previously hypothesized, and pulse pressure may be an overlooked blood pressure parameter. Further longitudinal studies addressing these limitations are needed. In addition, further investigation of the potential effect of antihypertensives on modifying the risk of developing glaucoma are needed. Thank you.
I think we'll probably have time for one question. Can you comment on diurnal versus nocturnal blood pressure? What its effects on?
They only took a single blood pressure measurement during the interview, so we don't have that data. Yeah. Thanks.
Thank you.
So no other questions then. Maybe we could ask Dr. Ella Berry to come and give us her presentation.
Good afternoon. Thank you for attending, and thank you to the organisers for giving me the opportunity to present in this session. I'm Ella, and my talk today is on physical activity and its associations with neuroretinal thinning in both glaucomatous and normative cohorts. So primary open-angle glaucoma is characterised by retinal ganglion cell degeneration, where beneficial effects of exercise have been proposed. While raised intraocular pressure is the most clinically treatable risk factor for disease progression, uncovering additional risk factors, modifiable risk factors, has important clinical implications. So we've undertaken a multi-cohort study between structural longitudinal thinning in a glaucomatous cohort and cross-sectional structural thinning in a population-based cohort. Progressor is a longitudinal clinical and genetic study aimed at predicting the risk factors of glaucoma. Participants have 6 monthly Humphrey visual fields and OCT scans of their macular ganglion cell interplexiform layer and of their retinal nerve fibre layer. In the primary analysis, I invited 512 participants from the Progressor study to wear a tri-axis accelerometer. For this study, we used a Fitbit Inspire 2, as shown in the diagram here. It's a small wrist-worn device that's very discreet, and patients generally really enjoyed wearing it. Only 13 participants out of the 502 didn't complete the 7 days of exercise wearing the Fitbit. And in the final analysis, following exclusions, the analysis was done on 735 eyes. Following adjustment for age, gender, and mean IOP, this scatter plot demonstrates a correlation between mean daily step count on the x-axis and the rate of change of macular thickness on the y-axis. So in the progressive cohort, a lower daily step count was correlated with a faster rate of macular GCIPL thinning. This finding was further tested by accounting for different number of cardiovascular comorbidities, and following this adjustment, a lower daily step count remained predictive of a faster rate of macular GCIPL thinning. This box plot takes the same data and we split the daily step count into tertiles. So comparing the higher tertile in the red to the lower tertile in the blue, the lower tertile correlated with a faster rate of macular GCIPL thinning. We looked at the structural progression endpoint, which was defined by the presence of replicated likely loss as per the Cirrus HD OCT guided progression analysis. Also adjusting for age, gender, and mean IOP, this Kaplan-Meier survival analysis is comparing time to structural progression endpoint between the upper tertile in the red line and the lower tertile in the blue line. A lower daily step count was correlated with a higher risk of structural progression endpoint with a mean follow-up time of 5.4 years. Correlating the daily step count with other glaucoma outcomes, a lower daily step count was correlated with a thinner cross-sectional macular GCIPL at the time of accelerometer acquisition. And then secondly, this study also assessed the correlation between daily step count and longitudinal retinal nerve fibre layer thinning, where we didn't observe any correlation. A sub-analysis performed on cross-sectional visual fields demonstrated a higher daily step count was associated with a better visual field mean deviation, that being less visual field damage at the time of accelerometer acquisition. A secondary analysis was undertaken using the UK Biobank, which is a prospective phenotypic and genotypic population-based study. Here we compared a cross-sectional analysis between a 1-week accelerometer measured physical activity data from over 6,000 participants with their total macular thickness from OCT imaging. After adjustment for age, gender, and mean IOP, this scatter plot demonstrates the positive correlation between accelerometer measured physical activity on the x-axis and total macular thickness on the y-axis. So in the UK Biobank, lower physical activity per week was associated with a thinner total macular thickness. So in conclusion, in a cohort of primary open-angle glaucoma suspects and early manifest disease, a lower daily step count was correlated with both a thinner cross-sectional macular GCIPL and with a faster rate of macular GCIPL thinning. Further to this, a lower daily step count was also associated with a higher risk of structural progression endpoint. And within the UK Biobank population, lower physical exercise per week was associated with a thinner total macular thickness. So these results implicate physical activity as a relevant covariate of neuroretinal degeneration, which may be relevant to glaucoma disease progression. So I'd like to acknowledge my co-authors on the research, especially my colleague, Dr. Henry Marshall, and my supervisor, Professor Jamie Craig, for their support and hard work while undertaking this project.
Thank you very much. So, some questions.
Can I ask the obvious question? So how do you know what's causation here? If you've got bad vision or you're myopic, you're obviously not going to go running. You don't know if you have seizure running. Or just decide if you have poor vision.
That's right. So in the progressor cohort, it's a study of both glaucoma suspects and early manifest disease. So about 2/3 of the patients undertaken in the progressor cohort were glaucoma suspects, and the relationship held true for a sub-analysis of that group. Yeah, and unfortunately for this study, we didn't look at the axial length.
And so we're extrapolating that 1 week of Fitbit wearing to what their general exercise regimen is like.
Yes, yeah. So obviously it's one of the limitations of this study, having just a single 7-day cross-sectional period of exercise taken. So conceivably people who don't normally exercise during this week got up and did a lot of steps, and those that didn't. I mean, it seems a little bit unlikely, and I think that's mitigated by having such a large cohort number of wearing the Fitbit.
Right. Well, thank you very much. In the interest of time, we're going to move on.
Next, we'd like to ask, thank you, Ella. Dr. Aaron Apt to come up to give his presentation on longitudinal analysis of structural and functional outcomes of epiretinal membrane in patients with uveitis.
Good afternoon. A group of us in Auckland set out to describe the long-term visual and anatomical outcomes of epiretinal membranes in patients with uveitis. We begin with a brief recap of the literature. In 2001, the Blue Mountains Eye study evaluated the progression of idiopathic epiretinal membranes by comparing stereoretinal photographs taken 5 years apart. Approximately 1/3 of them demonstrated progression, which was defined as an increase in the area involved by greater than 25%. Interestingly, a group of them also demonstrated regression over that time frame. Later in 2006, Govito devised an OCT grading system for idiopathic epiretinal membranes, which we have utilized in our study. And in 2020, the MARCH trials found that in their participants with cystoid macular edema, half of them had epiretinal membranes, and the presence of epiretinal membranes were associated with a lower likelihood of cystoid macular edema resolution. Epiretinal membrane was defined as a hyperreflective signal at the inner retinal surface. Importantly, in our study, there had to be evidence of contractility, such as spanning of the gaps across the inner retinal surface here. The Govito staging is outlined as follows. Stage 1, the foveal pit is present. Stage 2, the foveal region is tented upwards. Stage 3 is defined by the presence of these inner retinal layers, which are basically the continuation of the inner retinal layers across the foveal region. And stage 4 is similar to stage 3, except all the retinal layers are now disrupted and ill-defined. For the past 13 years, the Auckland Uveitis database prospectively recorded entries of 5,450 eyes or 3,925 patients with uveitis. And of these, epiretinal membranes developed in 216 eyes, approximately 4%. The etiology was infectious in a quarter of patients, and the median age was 57 years, which is about a decade earlier than what you would expect in idiopathic epiretinal membranes. I'd like to share with you 5 key findings from my research. Fellow eye involvement was identified as a novel, strong risk factor for epiretinal membrane development. If you had uveitis in both eyes and epiretinal membrane in one eye, your other eye had a 16-fold increased risk of developing epiretinal membrane. Intermediate and posterior uveitis were other risk factors that have been identified previously. The median visual acuity at baseline and final follow-up was 612, indicating overall stable visual function. A third of participants suffered moderate to severe vision loss, and this was not directly implicated with epiretinal membrane progression. Instead, it was more related to entities such as chronic systemic macular edema, macular atrophy fibrosis, glaucomatous optic neuropathy, and cataract progression. Which brings us to our third point. 7% of participants demonstrated progression according to Govito staging, and 5% demonstrated regression. So according to that, at baseline and final follow-up, the ratios of patients at stage 1 were about 80%, and stage 2 and 3 were 20%. So similar at both baseline and final follow-up. 20% of participants underwent surgery, and of these, majority of them underwent surgery after periods of 3 months of quiescence, and the median visual acuity at pre-op was 618. This improved to 612 at 1 year of follow-up. Approximately 60% of patients improved, 10% remained stable, 30% had worse vision, and the reasons for worse vision majority of times were due to cataract progression, but also due to other entities such as chronic systemic macular edema and persistent macular hole. Cystic maculopathy affected a third of our patients, and the majority of these, 94%, settled on medical therapy. However, if the macular edema persisted up to 4 months, the chances of resolution were much lower. Here's a summary of my take-home messages. Epiretinal membrane is more common in intermediate posterior and panuveitis, and if there is ERM in your fellow eye. Cystic maculopathy is common, but the majority will resolve with adequate treatment. And ERM peeling resulted in improved vision in majority of patients, but cataract progression and persistent macular edema may limit your visual outcomes. This study would not be possible if not for the tremendous support of my colleagues, Rachel, Sarah, Joe, and Lucy, and as well as Te Whatu Ora and Auckland University. Thank you.
Do we have any questions for Aaron? Yes.
Was there any relationship with the poor control with the risk of progression? Those 7% that progressed, did they have bad uveitis that went on for long no matter what we did?
I think certainly this was not looked at specifically. Majority of patients were, by the time of 3 months, were all fairly well controlled on their regimen. Certainly in really bad cases of uveitis, just by me, going through the notes, you could see that the majority of times bad uveitis would cause a lot of macular atrophy and fibrosis, as opposed to the epiretinal membrane progression.
So thank you very much. Next, I'd like to introduce Dr. Aaron Wong.
Thank you very much. My name is also Aaron. I'm also originally from Auckland, but I'm slightly less youthful. I'll be talking about research I was involved in as the glaucoma fellow in Auckland, trying to find better ways to predict which patients with uveitis go on to develop uveitic glaucoma. I'd like to acknowledge my co-authors, especially Rachel Niedera, who's the driving force behind this project. Wrong button. So this is my collection of real heart sink eyes. These are all patients with uveitic glaucoma, and sometimes they come in acutely, such as the patient on the left who's had a surgical iridotomy, or they're chronic patients such as the one on the top right with a slowly cupped disc. I think we all really, our hearts sink when these patients come in because we know they're hard to treat. We know it's hard to get good outcomes with them. And I think because they're often patients that come in for many years prior to this, we often think to ourselves, is there something we could have done earlier or better? And so that's why I think it's really important to find out whether we can target our screening to these patients better. And like was mentioned before, we were lucky in Auckland to have a large database of uveitis patients that were followed up for a long time. So this study drew from over 3,000 eyes with a mean follow-up of almost 6 years. In total, with all of those patients who had slightly different follow-up lengths, there was a rate of 6.3% developing uveitic glaucoma. And when you break that down by time period, over 5 years, 6.1% had developed uveitic glaucoma. By 10 years, the risk of developing uveitic glaucoma was 1 in 10. So I wanted to share 3 key findings from our data. I think the first is relatively obvious. The patients who had risk factors that we would normally associate with, say, open-angle glaucoma, were also at slightly increased risk of having uveitic glaucoma develop. These were presenting pressure being high and advancing age. And as you can see by the hazard ratios, they're only just over 1, so the risk increase was small, but it was statistically significant. We did not look at things like central corneal thickness, family history of glaucoma, or refraction. I think importantly, patients with risk factors for severe inflammation also were at higher risk of uveitic glaucoma, and in particular, patients who had chronic inflammation. The graph on the bottom left shows the development of uveitic glaucoma with time, with the chronic patients being the solid line and the acute or recurrent patients being the dashed line. And you can see by 10 years follow-up, they have almost a 4 to 5 times the risk of developing uveitic glaucoma. Also, interestingly, cystoid macular edema was statistically significant as a risk factor for developing uveitic glaucoma. This is probably due to the fact that patients with more severe inflammation get cystoid macular edema, and these patients also require more treatment with steroids. And thirdly, there is a variation in the risk, the rates of uveitic glaucoma by the uveitis diagnosis. So patients with viral uveitis, such as HSV, VZV, and CMV, had the highest risk of developing uveitic glaucoma in their follow-up, followed by chronic granulomatous disease such as sarcoid and TB. We expected that idiopathic uveitis would have actually a low rate of developing uveitic glaucoma, but it was actually around about the overall group rate. And so this is higher than we expected, and this may have been due to undiagnosed patients with granulomatous disease in this group. Fortunately, patients with HLA-B27 uveitis had a low ratio. So in conclusion, I think we can better target our screening of uveitis patients for glaucoma by looking at risk factors such as chronic disease, cystoid macular edema, and then concentrating on patients with high risk diagnoses. Thanks.
Thank you very much. So have we got any questions? Yes, Linda. No, we weren't. We didn't have that data, and it would be really, really interesting to know. Yeah.
Just leading on to that, sorry.
That's right.
Just with regards to the spikes in the intraocular pressure, you're sort of saying the higher the intraocular pressure, the more likely you'll progress, so it's a higher risk factor. Did you look at how high, like the spikes? Because I'm just sort of thinking about the last 7-year data with regards to the research. They found that, if they spiked over 25 or over 30, they were far more likely to progress. So I'm just wondering if you've done the same analysis.
We've got the data for the intraocular pressure at presentation, but not the spikes. So again, really it would be interesting to know though.
So just one last question, was that there, or? No, they're conferring amongst themselves at the start of a 10. So I think in the interest of time, we'll probably say thank you very much there.
Next, I'd like to ask Dr. Charlotte Jordan to come to the podium to present uveitis recurrence following COVID vaccination.
Good afternoon. I'm bucking the trend. My name is not Aaron, but I'm still from Auckland. And I'm also working with Dr. Rachel Niedera. I'm talking about a topic I think we'd all wish would just go away. But hopefully this is going to be something that you can take home some brief points and learn a few things. So we know that there's association between vaccinations and recurrent uveitis. And this is documented well in the literature. However, the significance and the risk factors for this is something we haven't been able to establish until now. With the onset of COVID-19 and the subsequent worldwide our vaccination effort, we had the unique opportunity to look at a population of patients with known uveitis and try and identify the significance of that association as well as the risks for uveitis flare. So I too also used the Inflammatory Eye Disease Registry at the Auckland District Health Board. We included standard nomenclature when recording the anatomical location, the type of uveitis, and when taking down this data. A uveitis flare was defined as the presence of new uveitis activity or increased activity that required a change in uveitis treatment. And the date and type of COVID vaccination was determined from the patient's clinical record. We also we looked at rates of flare 3 months prior to the vaccination and 3 months after. So we went through 3,770 patient records, and after exclusion, we included 3,008 patients. It was a total of 8,474 vaccinations. All except one was the Pfizer vaccine, and I will allude to some of the results. We had a large amount of data that we could draw from, but for the purpose of this study, I've abbreviated it somewhat. So when we look at the etiology of the uveitis, we could see a significant increase in rates of flare in both infectious and non-infectious uveitis. Most notably, the HLA-B27 uveitis and the sarcoid uveitis, which the increased rates flowed on to the second and third doses. This was also important in infectious causes such as the herpes zoster related uveitis. And this is the first study to report that the herpes zoster does increase after the COVID-19 vaccine. Toxoplasmosis was a little bit of an outlier. And what you have to consider in this data, at the time of recording, the patient numbers actually having had the third dose were low. And we need to further examine this data to see whether or not this drastic increase after the third dose is a true result. So when we looked at multivariate and univariate analysis to look at risk factors recurrence, we found that disease time course was significant, with both recurrent and chronic uveitis being significantly related with an increased rate of flare. Also, patients who had a smaller period of quiescence were more likely to have a flare, and the first vaccine dose was significant. Interestingly, the factors which were not considered to be significant were age, gender, ethnicity, anatomical location, and disease-modifying medications. Interestingly, we did find a significant increase in the intermediate uveitis group, increasing around 249% from baseline. So we know these patients are reasonably hard to treat, but when looking at multivariate, it wasn't a risk factor. So in conclusion, both infectious and non-infectious uveitis increased risk of uveitis flare, and whilst this is a small increased risk on a small but real scale. This is particularly important for those with poorly controlled disease, severe uveitis, shorter periods of quiescence, and in only eyes. And this is certainly not an advertisement for not advocating for patient vaccination, but it allows clinicians to weigh up the pros and cons of pre-treating prior to vaccination. And this is certainly an area that we need to do more further research on. It will also be interesting to see the implications of new vaccine subtypes with new formula and whether or not that has an implication long term. And that's me. Thank you.
I think we've got time for one question for Charlotte. Did you see any newly presented uveitis cases post-vaccine?
So we only recorded patient data from people who had a previous flare of uveitis. Certainly there have been large international studies who have suggested increased rates of uveitis de novo after the vaccine, but that's not something that we looked at.
Thank you.
And so now I'd like to call up our last patient, Dr. Paya Somalia.
Cool, thank you very much. So this is another study based in Auckland as well, with Rachel and other co-authors. So this is looking at smoking uveitic complications associated with smoking status. So in addition to nicotine, cigarette smoke contains more than 7,000 active compounds. These include alcohols, phenols, aromatic amines, aldehydes, ketones, aromatic hydrocarbons and metals, all of which can alter the immune expression and disease patterns. So smoking has been associated with increased risk of autoimmune diseases, including lupus, rheumatoid arthritis, and multiple sclerosis. With regards to ocular conditions, smoking is associated with worse outcomes with thyroid eye disease, and it's a significant risk factor in the development of neovascular age-related macular degeneration and anterior ischemic optic neuropathy. Previous studies looking at the effects of smoking on uveitis have found that smokers have greater risk of active disease, increased need for topical steroids to control inflammation. Smokers develop uveitis earlier, have a greater risk of bilateral involvement, and a higher risk of disease recurrence. So the primary objective of this study was to examine the association between cigarette smoking and the development of uveitic complications. The complications that we looked at included posterior synechia, ocular hypertension, uveitic glaucoma, uveitic cataract, papillitis, cystoid macular edema, epiretinal membrane, retinal detachments, occlusive vasculitis, and choroidal neovascular membrane, as well as the need for systemic immune suppressive therapy. So this was a retrospective observational study which used the Auckland registry, and it included patients that were diagnosed with uveitis at Auckland Hospital between January 2008 and December 2020. So we used logistics regression to examine the odds of complications in current smokers compared to non-smokers and ex-smokers, and then the results were cross-checked with ordinal logistics regression coding for non-smokers, ex-smokers, and current smokers. All tests were two-tailed, and a p-value less than 0.05% was considered significant. So there were 3,332 subjects with uveitis identified during the study period. Of this, 2,949 had a smoking status documented, so that's 88.5%. 3 subjects were recorded as vaping without cigarette smoking, so were excluded from analysis. The median follow-up was 2.5 years and the mean 5 years. So current smokers accounted for 9.9% of the study population and ex-smokers 15.5%. Females represented 52.5% of non-smokers, 40.7% of ex-smokers, and 39.9% of current smokers. There was a difference in the ethnicity that was observed as well, so Māori and Pacifica were overrepresented in ex-smokers and current smokers. So on univariate analysis, current smoking was associated with a higher odds of posterior synechia. When controlling for age and gender, current smokers were still associated with a higher odds of posterior synechia, but when controlling for age, gender, and ethnicity, posterior synechia was no longer significantly associated with current smoking. So smoking was associated with a higher odds of posterior synechia when controlling for age and gender. However, the difference became insignificant when ethnicity was also accounted for. So specific ethnic groups may be more susceptible for the damaging effects of smoking, and also ethnicity itself can also contribute to the development of smoking complications. And we do know that ethnicity does have an impact on the clinical manifestations and visual prognosis of sarcoid uveitis. And in a small study looking at pediatric non-infectious uveitis, non-Hispanic African American children were significantly more likely to develop uveitic complications compared to non-Hispanic white children. In terms of the rates of occlusive vasculitis and intermediate uveitis, panuveitis, and posterior uveitis, smokers had a decreased odds of occlusive vasculitis, but this didn't reach statistical significance. When comparing never smokers, excluding ex-smokers, the rate of occlusive vasculitis in smokers also appeared lower, but was still not significant. In terms of all the other uveitic complications, there were no significant statistical associations with smoking status. So in New Zealand, the government in 2011 were committed to becoming essentially smoke-free by 2025. And the prevalence of daily smokers has reduced over the years. So it was 18.3% in 2006. This reduced to 15.7% in 2013 and further reduced to 13% in 2018. So current smokers only accounted for about 9.9% of the current study population. So the low New Zealand smoking rates may have contributed to a lack of findings of strong associations with uveitic complications because the absolute number of complications in the smoking group was small. So uveitis is a heterogeneous entity. Genetic, lifestyle, and environmental factors may play a role in the susceptibility of various complications. Smoking may in some cases be involved in complications such as posterior synechia, and whether the association proves causation remains speculative. But despite the lack of a definitive causative effect, it's important that the treating ophthalmologist still counsel patients on smoking cessation for their general overall health, particularly based on the available data on the negative effects of smoking on all cause as well as cancer-specific mortality. And ethnicity disparities do need to be addressed in a culturally sensitive way. Thank you.
So any questions for Priya? Yes.
Look, great work, Priya. As if we needed another reason to tell people not to smoke. But we're on the cusp of smoking 2.0 with vaping. So obviously it's early days, but certainly there's a lot of epidemiological evidence building up about the threat that that's going to pose and the fact that we're very slow to address it. Any thoughts on how much of this will be translatable to that, given it's a different cocktail of poisons that we're using?
Yeah, it is different, and I'm not sure if the components within the vaping smoke are similar to the additional components apart from the nicotine in cigarette smoking, and whether that also has an impact on things, but it'll be interesting, to study in the future.
So we're bang on time. And so I'd like to ask everybody to congratulate our presenters for a very good session.